Hello, and welcome to the American Medical Association's Healthy Diet and Dietary Patterns webinar series. This is the first in a four-part series over the next several months that we're going to explore the changing policy landscape around healthy eating and dietary recommendations. Today's session will focus on the new U.S. Dietary Guidelines. I'm Dr. Bobby Mukamala, President of the American Medical Association, and I'm an otolaryngologist in private practice here in Flint, Michigan, and I'm certified in lifestyle medicine. Before we begin, I want to thank you for the questions submitted during registration. You can also join the discussion and submit questions at any point during the webinar by submitting questions to the Q&A. We will get to as many of those questions as we can during our discussion. The AMA has long recognized the important role that diet and access to healthy foods play in the health of our patients. In 2017, when I served as chair of the AMA's Council on Science and Public Health, we reported and then adopted valuable policy strategies to reduce the consumption of sugar-sweetened beverages that so often contribute to poor health for adults and children. Since that time, we have adopted policy on and advocated for policies to reduce sodium in food, improve nutrition labeling, and support increased awareness and research on ultra-processed foods. In January, HHS released a new set of U.S. dietary guidelines that further highlighted the health risks of diets high in sugar and ultra-processed foods. Today's webinar is intended to provide an overview of the history and impact of dietary guidelines in the U.S., to discuss what physicians need to do to know about these latest guidelines, and share practical strategies for counseling patients on diet and eating patterns. I'll introduce our esteemed guests, each of them nationally recognized experts in the field of nutrition. After their presentations, we will move into a Q&A session to address your questions. First, I'd like to welcome Dr. Christopher Gardner. Dr. Gardner is the Renberg-Farquhar Professor of Medicine at Stanford, a nutrition scientist, and has been a key faculty member at the Stanford Prevention Research Center, where he leads the Stanford Nutrition Studies Research Group. He is recognized as a leading expert, both nationally and internationally, on what to consume and avoid for optimal health, and how to best motivate individuals to achieve healthy dietary behaviors. Second, we'll hear from Dr. Dariush Muzaffarian. Dr. Muzaffarian is a cardiologist, public health scientist, and director of the Food is Medicine Institute at Tufts University. He is a globally renowned expert in food is medicine and has authored more than 600 scientific publications on nutritional priorities for cardiometabolic health, as well as evidence-based policy approaches and innovations to advance nutrition security, reduce diet-related diseases, improve health equity, and reduce healthcare costs. Full bios for all our speakers are available on the event page. We're very excited to have both of you guys with us today. Let's get started. First, we'll hear from Dr. Gardner.
Great, thanks for having me here. And this opening slide, which I assume everyone can see, is an interesting overview of 45 years now of dietary guidelines, I think initiated by Senator McGovern back in 1980. When there was a lot of food issues going around, and they came up with these for the first time and said, and I'm not sure I'm getting all this absolutely correct, that as we go forward, I'm sure there will be new evidence. So what we'll have in place is a federal guideline to update these every 5 years. And so what you're seeing here is sort of the covers of each of those 5-year updates. In the early days, and again, I'm not sure if I'm getting this right, but I've heard this from Marion Nessel, who's always been very active in the nutrition world. There was a committee assigned to come up with the questions and rewrite the guidelines. So as time has gone on over this period, it's changed quite a bit. And I actually just recently served on the official Dietary Guidelines Advisory Committee of 2025. And so let me tell you some of the changes that have taken place over time. At one point, it was decided that the scientific committee would create an advisory that would be turned over to Secretaries of Ag and Health and Human Services. I've always thought that was kind of interesting that the two groups split it. One might think Health and Human Services would be more objective, given that ag represents cattle and dairy and legumes and fresh fruits and vegetables. And could be some conflict of interest there, but there also could be some opportunities to implement dietary guidelines for Americans if it was closely aligned with agriculture. Anyway, it's moved forward that way such that at least for the past 10 or 20 years, the two secretaries rotate primary responsibility. And this last time, it was Health and Human Services that took the lead. And the time before that, it was ag that took the lead. The other thing that changed here was that for many of these sessions or updates, it was the scientific advisory group that chose the questions. Dari might know the answer that I might be missing here, but I believe it might have been the year that one of the advisory committees chose to link environment to food. And Secretary Vilsack said, that's not going to happen this year. We are not linking food to the environment. That's not the purview of the Dietary Guidelines group. And I think it was after that, that as the new Dietary Guidelines Advisory Group was selected, the questions were pre-selected for them. So these advisory groups, at least when I was just recently on it, are selected 2 years prior to updating the guidelines. And there were 20 of us. And the idea is that we would get nominated by different people, vetted. We were told up front that it would be 1,000 or so hours. It would be 10 hours a week for 2 years. We would meet twice a week on Zoom. We would have side meetings. We would be reading hundreds and hundreds of papers. We would have the help of an incredible federal staff that would help us in identifying which papers to use and extracting the data for us. So if I could go to the next slide, this is sort of an overview of the timeline that after the study questions are identified and after the committee is appointed, we spent 2 years doing this, which included going to Washington, D.C. 6 separate times and having a full day of public meetings. This might be a little too much information, but the way this worked, we spent the first 6 months of our 2 years working on PICO guidelines. So PICO would represent the population, the intervention, the comparison group, the outcome of interest, and the time, the duration of time. For example, for something with a cardiovascular, cardiometabolic risk factor like blood pressure, blood lipids, it might be a 4 or an 8-week time period. For something like observational epidemiology with hard outcomes, it might be a minimum of 5 years or 10 years or as little as 1. So it was pretty interesting that we took 80 questions that were given to us initially. We prioritized them as high, medium, and low. We decided we would try to focus on 60 of the 80 questions, and then we would work through PICO guidelines for each one of these, turn these over to the federal staff that were helping us. They would come back to us and say, look, given the PICO guidelines you gave us, there's no evidence found for this, no published papers, or there's 1,000 papers, and you don't have time to read 1,000 papers. Would you like to narrow the guidelines or broaden the PICO guidelines so that you get a reasonable number of papers to look at? So we did that for months and months before ever addressing any of the questions. But then once that was done, we still had about 1.5 years left. And each of the committee members was assigned several questions. I'll just give you one quick example of myself. Deanna Holscher and I were assigned food sources of saturated fat. And that doesn't actually sound like a question. So it was more of a topic. And we took that topic to the PICO guidelines and said, okay, for these food sources, probably for populations, this is kids, adults, and elderly. And there were really only papers for adults. And for the sources, the exposure, that was either meat or dairy or tropical oils. And for the comparators, that could have been whole fat dairy versus low fat dairy, fatty meat versus lean meat. But because this focus was food sources of saturated fat, it could also have been meat versus lentils and legumes, or it could have been versus whole grains. So past that, looking at the outcomes, a lot of these were cardiometabolic outcomes, lipids, blood pressure. Some of them were hard outcomes. And it turned out that our one question that we were assigned, or the one topic, food sources of saturated fat, if you can picture all the permutations of those PICO guidelines, there were actually 31 separate questions that we addressed. And after giving our PICO guidelines, 14 of them did not have adequate evidence to even try to address. 17 of them did. Once we looked at all the literature that was very helpfully extracted for us, we figured out if there was a direction, yes or no, it's not related, it's harmful, it's beneficial. Then we had to go through the grade process where we went to see if it was generalizable, consistent, what was the precision, what was the rig of bias. I think I'm forgetting one factor. And then we had to grade it as being strong evidence, moderate evidence, or limited evidence. So for that one topic, we actually came up with one strong conclusion, about 10 moderate conclusions, and something like 6 limited conclusions. Now, after this was all done for all 60 questions that we looked at, all the leaders and teams, we were actually in 4 different subsets, had to present all of our findings to the entire committee so that there was consensus. We had to do this very publicly so that the public could see this and all our colleagues could see it. And we ended up generating a 423-page report and a 1,000-page supplement, which was what we submitted to the Secretaries of Ag and Human Services. And that was in December of 2024. And as it was explained to us in the beginning, that was an advisory document. And the secretaries were not obligated in any way to take our advice. We had a 12-page executive summary. We even had a 2-page overarching advice to the secretaries. Like, of all the things we worked on, these seemed to be the most compelling. So you could look at the 2 pages or the 10 pages or the 420 or read all 1,000 of the supplement. That was our advisory report, and our job was done. Once we finished, it was out of our hands and up to the secretaries to create and generate over the next year. Again, this is December of 2024. They had all of 2025 to put that to use to generate new guidelines. Now, if I could go to the next slide. The nitty-gritty that you're not seeing here is part of this was a data analysis of what Americans eat now. Part of it was the systematic reviews, which is pretty much what I just shared. There's also a very interesting food pattern modeling mechanism or tool that we created. And I don't have time to talk about it now. So if somebody asks me about this, I can explain. We use that in a very limited way. The tool has been created. I really hope others will follow up and use this extraordinary tool that was created. Basically, what happens if you recommend less of one food and replace it with more of another? What happens to all the vitamins and minerals and nutrients that would come from that? And is that a positive change or is that a negative change? We only did that for a couple of questions, but the tool is there. Now, if I could go to the next slide. So when the dietary guidelines are made and when they're available, this has happened time and time again, we made use of the National Health and Nutrition Examination Survey data, which is available online as What We Eat in America. And this is the data analysis we did of the recent NHANES data. And hopefully what you can see from this graphic is for total veggies, dark green veggies, red and orange, beans, peas, and lentils, starchy vegetables, other vegetables, and fruits, the American public is way below recommendation. Whole grains, they're way below recommendations. Total grains, it looks like it's kind of in the middle. But if you look at the orange figure that orange bar that I've circled, most of the grains are refined grains, and those were never recommended. And so those are above what we wanted people to eat. You can see that skip over a couple, the total protein and the meats, poultry, and eggs are, most people are getting what the RDA is or more. And then we got a couple other categories suggesting, maybe the oils are kind of centered there. Some are eating more, some are consuming less. The bottom line here is, as has been true for a long time, the general American public does not follow the guidelines. So the place where the guidelines are followed, and we'd be happy to get into this later, is National Food Safety Net program. So school lunch, school breakfast, women, infants, and children. Not so much SNAP. We could get into that. There's a little variation there for SNAP, but most, I think there's something like 20 plus federal safety net programs. And in general, that's actually where the guidelines are most strongly implemented and followed. And so these do have important implications for those. But for the general public, many people don't even know what these are, don't follow them. Can I go one more slide, please? And then I'll hand it over to Dari. A really fascinating part of our work, which I actually found initially very frustrating, and then now that the period has passed and we've finished, it was incredibly transparent. The methodology for the setting the PICO guidelines, doing the search, having to make public announcements if you were changing the criteria of the search, having to make public all the conclusions you made and all the papers that were cited to generate those strong, moderate, or limited conclusions, those all went into the supplemental materials. The 6 days of public speaking and public presentation were amazing. We took over, I think, 10,000 public comments that we were required to review every time we had a public meeting. Very, very transparent every step along the way. There really wasn't any place for anyone to sort of sneak in their little pet project or their personal bias according to some category. All the committee had to agree, and all of this had to be shared very publicly. So it was very systematic, very methodical, very transparent, very public. And to be honest, it was really an honor and a privilege to participate in this. And then it was a little bit frustrating to learn, but we knew up front, after all this was done on December 2024, we handed this over and knew that nobody might pay any attention to our work. It was an advisory document and our job was done. I think we actually got a note the next day that said, please don't refer to yourself as a member of the committee. Refer to yourself as a past member. Your job is done. So let me set up Dari with that background. How's that, Dari?
Well, thanks a bunch, Dr. Gardner, for that very informative presentation, the inside baseball of all that provided great context for the U.S. Dietary Guidelines. And yes, next we're going to hear from Dr. Muzaffarian. Dr. Muzaffarian, it's all yours.
Yeah, thank you. So thank you, Dr. Mukamala. And I'm very impressed with a surgeon who is lifestyle medicine certified and believes and understands in the fundamental nature of lifestyle for health. I think that's great. And also thanks to John White, the CEO of the American Medical Association. I think the two of you and others are really helping move the American Medical Association toward understanding and advocating for integrating nutrition into healthcare where it belongs. And I'm a cardiologist. I have a PhD as well. And you know why I focus on nutrition. I mean, this slide summarizes it all. If we care about health, food has to be the number one priority that we address in healthcare. Not top 5, not top 10. Actually, the number one priority. And if we think about where food is in sort of the hierarchy of what healthcare addresses, it's not even probably in the top 50 things, let alone top one. More people are sick today than are healthy. Being healthy is now the exception. And most of this is related to poor nutrition. And most of this has happened not only in our lifetimes, but in our adult lifetimes. When I graduated medical school in 1995, we were just at the beginnings of this crisis. And so this has really happened in the last 3 decades. And so today, half of adults in our country have diabetes or prediabetes. Half. 3 in 4 have overweight or obesity. And if you add just blood cholesterol and blood glucose levels, let alone many other risk factors, 14 out of 15 adults age 18 and over have suboptimal cardiometabolic health. So most people are walking around sick, and this has become normal for them. So they don't even realize they feel sick. And this is really the challenge. And this starts young in teenagers. 1 in 4 have prediabetes, and recent estimates that might even be as high as 1 in 3. 1 in 4 have overweight or obesity, and at least 1 in 6, and in some estimates 1 in 4 have MASH, liver disease from poor diet. And we and others have done careful calculations to estimate how many deaths are directly caused by our food. And we estimate 10,000 Americans are killed every week, far more than were ever killed by COVID due to poor nutrition. And 16,000 new cases of diabetes are diagnosed every week, and 1,500 new cancers every week from poor nutrition. And a few years ago, this was estimated to cause $1.1 trillion in excess healthcare spending and lost productivity by the Rockefeller Foundation and McKinsey. And with inflation and costs, this is probably closer to $1.5 trillion every year. And this leads to lost wages due to rising employer healthcare premiums, Personal bankruptcies, the #1 cause of bankruptcy in the United States is rising medical debt. The federal budget, state budgets are strained. US businesses are strained by their healthcare costs. Military readiness is reduced. This is a crisis and one that we can actually fix. Next slide. And Dr. Gardner set this up very well, talking about the history. I'm going to kind of focus on two big areas of the guidelines. The 1992 food pyramid, which many Americans actually still believe exists, even though it was retired in 2011, sort of summarizes what the guidelines were between roughly 1980 and 2010. For those 30 years, they were heavily grain focused. They were heavily carb focused, low fat, low fat, low fat. And so you can see the base of the pyramid was grains, 6 to 11 servings of grains without any real focus on whole grains or just modest focus on whole grains. And so Americans responded. Over this period, the average calories consumed or available to Americans from refined grains went up by 300 calories per day per person, more than any other food group by far. And so that's the biggest change that happened between sort of 1980 and 2010 was and as Christopher showed, by far the food group that's most overconsumed by Americans is refined grains, far more even than added sugar. We focus a lot on added sugar, and sugar sweetened beverages are a problem, but outside sugar sweetened beverages, far greater the problem than sugar sweetened beverages is refined grains. And I want to just spend a little bit of time to look at the pyramid, because why do we have a pyramid? And this will become relevant when we look at the new pyramid. The reason a pyramid is relevant is because of the space that each food area takes up. And so the biggest area is the base, where there's bread, cereal, and rice. Then the next tier, equally distributed between fruits and vegetables. The next tier divided between milk, yogurt, cheese, and other protein foods. And at the top, all fats, oils, and sweets put together. So extra virgin olive oil, avocado oil, avocados, all grouped at the top as things to avoid, right? So this was the message that Americans got for 30 years. In 2011, this was updated to My Plate. And in 2015, actually, the focus on low total fat was dropped quietly. But if you really look at My Plate, it's actually not that different from the original food period. Dairy and protein, fruits and vegetables are about the same proportion as they were before. Grains were maybe reduced. So maybe the biggest difference in My Plate is grains are reduced. They're just kind of among the other foods now. And so every food kind of has equal representation now, rather than grains being at the base. But there's not much focus here on whole grains. It's all grains, and the recommendation was really for at least half of grains to be whole grains, which meant that it was sort of implicitly saying at least half could be refined grains. And so this wasn't that different in 2011. Again, maybe grains were a little bit reduced. Next slide. And if I've looked at the science, this is sort of my summary of where the science is. I think there's foods that we need to eat more of, foods that we need to eat in moderation, and foods we need to eat less of. And this doesn't really match My Plate or the 1992 pyramid. At the top are fruits and fish and vegetables, plant oils, whole grains, beans, and yogurt. These are the foods with the strongest scientific evidence for benefits, not just for cardiovascular disease and metabolic health, but also for weight gain, for cancer, for gut health, for cognitive decline, for healthy development in children, really for every chronic disease outcome. These foods come up again and again and again. And you can see that it's not like protein foods are all in one place, or plant foods are all in one place, or fats are all in one place. It's really about the foods that actually have evidence for protection. And then, there are foods to eat in moderation. And I don't know why we would call these protein foods or fat foods. They're not protein foods. They have lots of different things that they contribute. And they're not, either also just foods that contribute fat. And then the worst foods in the food supply are processed grains, starches, and sugars. And we've already mentioned, again, this is a big problem. Probably the single biggest two problems in the US food supply in terms of negative things are salt and refined grains. Next slide. So what's new? How did 2025 change what was in the past? So some things didn't change at all, or very little, if at all. A relatively similar emphasis in terms of both how much they're prioritized and the servings recommended for fruits and vegetables. So that's been consistent, and that's been consistent really since 1980. Hasn't changed. Fruits and vegetables have been recommended 2 to 3 servings per day of each. To limit sodium, that was recommended, and I think that's important. There were some stirrings and some hints that maybe that was going to be either stronger or weaker, and it was left the same. Saturated fat was retained, the limit at 10% energy, and we can talk about that more and if that actually makes sense, given some other changes in the guidelines, but it was retained. So those things weren't changed. I think there were some pretty big changes, and I think the single biggest change is the guidelines really emphasize at the highest level for the first time to eat real food and to avoid, highly processed foods. If you look at prior guidelines and you really read down into the appendices, there are statements about, eating, foods that are less processed and avoiding certain foods, but it wasn't the top priority of the guidelines. The guidelines were more nutrient focused, more about avoiding saturated fat or sugar or salt. These guidelines really talk about, could you please go back to the previous slide? These guidelines really talk about avoiding packaged foods. And so these are all new, really new emphases in the new guidelines. And the wording here is actually also important. The guidelines for all of these say avoid or limit. Those are strong, strong words for dietary guidelines. Dietary guidelines might say moderate or reduce, but avoid or limit are very, very strong words. And these are the foods that are recommended now to avoid or limit: highly processed, packaged, or ready-to-eat foods. That's a lot of foods. Other foods that are salty or sweet, sugar-sweetened beverages, added sugars limited to 10 grams per meal and 2.5 to 5 grams per product, which is quite low. For the first time ever, artificial flavors, colors, preservatives, and sweeteners, including natural low-calorie sweeteners, and highly processed refined carbohydrates, which, as we've mentioned again and again, is about 25% of calories in the food supply. If you put all that together, that's about 60% of all foods in the food supply. So I want to just, again, really step back and emphasize how groundbreaking this is. In every prior iteration of the dietary guidelines, the scientists, the dietary guidelines advisory committees, like Christopher sat on, have said to avoid refined grains or to avoid sugar-sweetened beverages or to avoid processed meats, or they've said some of these things. But when those guidance has reached USDA and HHS, those have been quietly dropped and replaced with nutrient targets. So rather than saying avoid sugar-sweetened beverages, the guidelines would say, keep your sugar under a certain amount. Rather than saying avoid processed meats, it would say keep your saturated fat below a certain amount. That's really hiding the harms of those foods behind nutrient targets. And Americans don't know, how much percentage of calories they're eating from X or Y or Z. So really the message of prior guidelines were there are no bad foods. Everything in moderation is okay. Eat a, quote, balanced diet, eat a variety of foods. I think those are all actually industry messages to eat everything in moderation, and there are no bad foods. There are bad foods. There are foods that are actually killing Americans and harming Americans. So this is a shot across the bow, or actually a shot at the bow of the food sector, saying that 60% of the foods in the food supply Americans shouldn't eat anymore. So that's a big deal. And then the other things that they recommend that I think are really a change in emphasis is they really emphasize that if you're going to eat grains, they should be fiber-rich whole grains, not at least half, which is what they said before, but that all grains should be fiber-rich whole grains, and that's a big change. To embrace healthy fats from whole foods, and again, that's a big change. Prior guidelines have still been sort of fearing of fat, and so they would say, eat strawberries with no caveats, but they would say, eat avocados and nuts, but be careful, they're energy dense, then you might cause weight gain and so on, even though there's no evidence that nuts or avocados or salmon or other fatty foods cause weight gain. They would still always have a caveat around fatty foods. That's been dropped. And so they really emphasize embracing fats. They do say to prioritize oils with essential fatty acids, and that means actually polyunsaturated fatty acids, omega-6 and omega-3. They didn't call that out, but that is what that means. And they say that you can include whole fat dairy with no added sugar. That's a big, big change. For the first time ever, the dietary guidelines say that you can include whole fat dairy with no added sugar. And that's actually supported by the evidence. The DGAC committee that Christopher sat on found no meaningful evidence that low-fat dairy was better than whole-fat dairy for any health outcome. And so I think that's also evidence supported. And then lastly, the guidelines recommended to prioritize protein foods at every meal. That's not new. They said to include both animal and plant sources. That's not new. They said, red meats, poultry, eggs, dairy, lentils, legumes, soy were all choices. That's not new. The only thing that was really new about the protein recommendations were they increased them from 0.8 grams per kilogram per day, which is what's recommended for the average adult, to 1.2 to 1.6 kilograms grams per kilogram per day, which is what's recommended for people who are strength training. So it's not unreasonable. They basically are implying everybody should be strength training, and so the higher protein would be better, although I wish they had said that. But importantly, from a practical perspective, most Americans are already eating that much protein. There's no protein shortage. And so it really doesn't, from a technical perspective, change the prioritization of protein. But from a messaging perspective, I think it does, because industry now is going to take this and use it to market highly processed protein foods rather than actually real foods. Next slide. And in terms of the imagery, they released this food pyramid. So I think it's mostly fine, actually, but I think they tried to be a little too cute. And so I think they did two things which I don't think they had to do. First, they did it upside down. And I think, that was to point out that they're like overturning everything that we've ever known about nutrition, even though, a lot of the things were consistent with the science. So I didn't think they needed to do it upside down. And then secondly, even though, again, a pyramid, what matters is the area that a food occupies, whether it's the bottom tier or the middle tier or the top tier, not where it is in the pyramid doesn't actually matter. They put red meat in the very first left thing that you see. And so your eyes drawn to it. But if you look at the pyramid, for the first time in history, vegetables and fruits are at the base of the pyramid. Even in 1992, vegetables and fruits were in the middle of the pyramid. They were in the second tier. So now, for the first time, vegetables and fruits are actually at the base, which is a positive. Protein, dairy, and healthy fats are also at the base. So their point is that grains should not be at the base. And they've put, protein, dairy, and healthy fats on equal footing with vegetables and fruits. Not higher, not lower, on equal footing with vegetables and fruits. And if you look at the overall pyramid, about 60 or 70% of it is plant foods, and about 30% of it is animal foods. And among the animal foods, there's a mix of dairy, fish, poultry, meats, cheese, and then there's whole grains. And so I view this as three pillars, as a triangle with three pillars: whole grains, vegetables and fruits, protein, dairy, and healthy fats. Next slide. And what I have done is just with AI, I just sort of flip this left to right. It's the same proportions, it's the same positions, everything's exactly where it was before. But if they had released this, people would have said, oh yeah, this makes sense. Vegetables and fruits, make sense. Protein, dairy, and healthy fats, whole grains. So again, there's a little bit of cuteness here. There's messaging about steak, but really the true explicit guidelines don't emphasize red meat more than other guidelines. But I do think that HHS and its independent messaging and public statements has emphasized steak, but the guidelines themselves don't. So looking forward to our continuing discussion. Thank you.
Thank you very much for that fantastic summary and comparison of the newly released US Dietary Guidelines, Dr. Mozaffarian. And a big thanks to both of our presenters for sharing all these valuable insights, the history, interpretation of what we're seeing now on these US Dietary Guidelines. I'm sure there's going to be questions, and so let's get to those now. We'll start with some of the questions that our audience already submitted, and then I would encourage you to, anyone that's watching, to continue add questions. We'll get to as many as we can get to. So starting off, can you comment on the dietary guidelines and what should be considered and what to watch out for patients or for people in general that are on a plant-based diet?
So can I comment on that? I will
Please.
say that if you read through the guidelines, there is a section, if you go to the very end, they actually have a section on vegetarian and vegans. And this is actually related to that food pattern modeling that I brought up earlier. And this is really subtle and slipped through. And a guy named Kevin Klatt, who's a wonderful dietitian and a new faculty member, University of Toronto, looked into this more deeply. It actually says vegetarians and vegans can eat this and that, and that's probably okay, but there's about 15 nutrients that they're likely to be short on, and so we would like to bring that up. And for people who follow a plant-based diet, but 15 nutrients being short on seems to be not trivial. That seems to be really important. If you read through the literature that supports this statement, Bobby, this was a result of the food pattern modeling. I was privy to this when we had this discussion. It was one of the very few exercises that we actually did with the model. When this was presented to the Dietary Guidelines Advisory Group, they said, okay, we took the healthy US diet, and we took all the meat and dairy out of it, and these are the nutrients that were short. And I said, well, as food pattern modeling, what did you replace it with? They said, we didn't replace it with anything. I said, what do you mean you didn't replace it with anything? So this is far fewer calories than the original. And they said, yes. I said, why didn't you replace it with anything? I said, we couldn't decide what to replace it with. There's so many different options we could have replaced it with. So we simply took it out. Personally, I was furious. I said, I can't believe this is the exercise that you just did. How can you say these are the nutrients that are missing after removing all meat and dairy and not replacing it with more beans, more nuts, more whole grains, more vegetables? It just doesn't make any sense. And at the time, I let it pass. Like I kept bringing this up, and they said, no, we have to move on to the next issue. This part came at the very end, Bobby. So there wasn't a whole lot of public discussion or committee discussion about it. But when you look at the standards of the foundational science for this, you can see that that's where that statement was drawn from. So it's a totally inappropriate, fear-mongering statement of a model that wasn't correctly used. And I personally find that really problematic, that it wasn't presented with greater transparency.
I would just add a couple things more broadly, not about the process itself, but about vegetarian and vegan diets. So I think many people who sort of grew up in vegetarian or vegan cultures or traditions or implemented carefully can have amazingly healthy diets and certainly get all their nutrients and that they need, as long as they sort of pay attention to some nutrients that may be harder to get. I think that's perfectly fine. The challenge is that many people switch, midlife or early life to vegetarian or vegan diets without doing that. And in fact, their health gets worse. I've seen this in my own clinic. They gain weight because they're switching to rice starch and cornstarch and wheat starch and thinking these are fine. And they're just eliminating animal foods and again replacing with highly processed foods. And so I think the key message is you can have a really healthy vegetarian or vegan diet, and you can have a really healthy omnivore diet, and you could even have a really healthy, mostly animal-based diet if you really try hard. Or you can have an unhealthy version of all of those too. And so just being vegetarian or vegan by itself doesn't define healthfulness. You really have to think about your food choices.
Absolutely. No, thank you for that. Here's an interesting one. Could you comment on dietary guidance for patients who are undergoing cancer treatment? Because, I think the interpretation of this pyramid is for everybody. But clearly the first reaction we have is to clarify and say, this is, if you have something going on like cancer, there's other things to consider. So what do you say to somebody like that?
Let me start that out again and just say that the guidelines very specifically say that DGAs are meant for healthy Americans. They're not meant for Americans with conditions. And interestingly, in the evolution of time, over time, this was also not intended for Americans that were overweight or obese. And maybe 10 or 15 years ago, Dari, maybe you'll remember more than I, it was obvious that most Americans were now overweight and obese. And so that if you just said healthy Americans that have no obesity and no overweight, who are you speaking to now? So a little while back, they said this does include Americans who are overweight, but it does not include people with cancer or heart disease or chronic kidney disease. Those are intended to be separate. Dari, how would you respond to that?
Yeah, Christopher is exactly right. So about 25 years ago, NIH and USDA, because by law, the dietary guidelines are for a general healthy population by statute. They're not supposed to be to address disease conditions. And so USDA and NIH kind of divvied it up. And NIH said, we're going to put out guidelines for disease conditions for diet, and USDA do it for the general healthy population. And the NIH did that for many years. They had the adult treatment panel for cholesterol and or the NCEP panel for cholesterol and the adult treatment panel for hypertension. And they had these guidelines for people with disease conditions. And then Francis Collins, around, again, 20 years ago, 15 years ago, said, we shouldn't at the NIH be in the business of generating science and interpreting science, or we're going to get out of the guidelines business. So all of those things stopped. And so for at least 15 years, there's been no specific guidance for anybody with a disease condition. And so these guidelines don't actually address people with disease conditions. The 2025 guidelines do, in a couple of footnotes, mention this. They say people with diabetes, perhaps very low carbohydrate diets or ketogenic diets could be helpful. They do mention it in a couple of places. But we just don't have the science to really give definitive answers about nutritional recommendations for people with ongoing cancer or in remission from cancer. We are at Tufts at the Food as Medicine Institute. We've completed, one of our faculty has completed the first ever randomized controlled trial of medically tailored meals in cancer. We're submitting other grants. We need to fund a lot more nutrition science with definitive large randomized trials, definitive large mechanistic studies, much better observational studies to answer some of these questions. We understand diabetes and cardiovascular disease. I'd argue we kind of understand obesity. We don't understand obesity that well. We don't have very good understanding of diet and cancer, diet and mental health, diet and other outcomes. So I think it's a big gap. And then I guess the last thing I'll say is yet the overall signal we've seen again and again and again is that this rough dietary pattern works for most things. And so I doubt it's going to be dramatically different, but there might be very specific important nutrients and things that reduce inflammation or that reduce angiogenesis or that activate, T cells. There might be, specific nutrients like that, but I don't think we're there yet.
And to build on that, I mean, maybe the NIH isn't putting this out, but there is an American Cancer Society, the American Heart Association, American Diabetes Association. They all put out guidelines and update them regularly. The newest American Heart Guidelines came out this morning, actually.
So here's one. How can primary care physicians effectively integrate the dietary guidelines into their practices? I mean, the financial challenges of just running an office, but yet ensuring personalized, sort of culturally sensitive care. I mean, it's difficult for a primary care physician to do. What would your advice be as one of the first steps to do?
So yeah, I'll start there. So this is not a problem that can be solved alone by the practicing doctor. There are steps that a doctor can take, and we can talk about that. But I think first and foremost, we need systems change to make this easier. And that systems change has to start in training, in medical school, residency, fellowship, and continuing medical education. It has to start in the EHR. It has to start in clinical care referral pathways. It has to start in reimbursement and all the things that make doing something as a doctor easier to do. And there are analogies. So for example, we learn about smoking screening and smoking cessation. We have billing codes. We can refer patients for smoking cessation. We have ways to learn about and screen for and address mental health issues. Opioid disorder, other illicit drugs. Every resident learns how to do, medical student learns how to do a SOAP note and ask about illicit drug use. And then if they find it, know what to do about it. Physical ailments. If somebody has a physical problem or a joint problem or back pain, we know about physical therapy and assessing that and referring them for physical activity. And we have, offices and billing codes and physical therapy schools and physical therapy buildings where people can go get that treatment. Nothing like that exists for nutrition. So we can do it for mental health. We can do it for smoking and other substances. We can do it for physical activity, but we can't do it. Cardiac rehab is another example. Right after a heart attack, we can refer patients for cardiac rehab. We don't have that nutrition rehab. We don't have that nutrition therapy well established. Of course, there are RDNs who are excellent, but they're not often reimbursed for some of these things. So I think ultimately, all of us, and particularly the American Medical Association, but all of the individual members, while we're trying to fix the problem in our own offices, we have to fix the problem nationally. And so that starts with advocating for and strongly supporting medical nutrition education at all stages of training. And the AMA, I think, is going to be a leader in this, and I'm really delighted by that. I think it starts with making sure the EHR has nutrition tools integrated into it, and there's clinical care pathways. We have to advocate to Congress for billing and reimbursement for addressing nutrition. We have to advocate for RDNs being covered when we refer patients to see RDNs. And so I think we could do that in a year. I mean, we could change all this and fix it. So I think that's got to be the biggest step. To go back, what to do today, I think that reading the dietary guidelines, reading trusted sources like some of those that Christopher mentioned. The average doing a ACLM certification or some other certification, a doctor should first train themselves. And then, you can, especially if you're seeing somebody repeatedly over time, assess their diets with very basic questions. What's your average breakfast? What's your average lunch? What's your average dinner? What are your snacks? You can really get a pretty good picture of what a person's eating. And then working with them, go through evidence-based lifestyle change therapies, set proximal targeted shared goals, have self-monitoring, have peer support, all the things that I do with the cardiology fellows here at Tufts in downtown Boston. So there are ways to address it. The challenge is everything stacked against the busy primary care doctor to do so. And so to do so, you have to kind of fight all that, but I think it's worth it.
Can I add that in the past, and I think it'll take time to see if this also develops with the recently updated guidelines. So the past DGA was 164 pages, and I remember RFK Jr. complaining about that, saying ours are going to be 4, and I think they ended up being 10. They are short, but really what's happened in the past is it's set up front. These are meant for health professionals who really want to know to implement their program, what references, what citations can they go back to. This is pretty geeky. It is not meant for the general public, but what we'll do is we will create handouts, pamphlets, assets, shortened versions, coloring books. So in the past, all that science was also translated into other shorter versions at a lower reading grade level, et cetera. So there have been all kinds of materials that have been created in the past. It would be nice to know that soon this administration will also create those complementary supplemental materials that would be more accessible to healthcare professionals who don't have the time to read all the studies in the background and the citations. And hopefully that will happen, but we'll wait and see.
Yeah, and next question is one that I see on TV all the time, GLP-1s. So what do you say to a patient about their nutrition, the information that we can share with them when they're prescribed a GLP-1?
Well, so this is absolutely crucial. And I think first, hopefully we can put it in a link. We've published a 4-society paper with 4 of the major societies addressing obesity and nutrition on how to address nutrition with GLP-1 users. That was published in 4 journals a few months ago. So we're happy to share that, and hopefully we can put a link to it online so the interested viewer can look for more detail. But I think the first take-home message is that it's, I think, medically wrong and economic suicide for our country to be prescribing GLP-1s without wraparound nutrition and lifestyle support. GLP-1s are explicitly FDA approved as an adjunct to nutrition and lifestyle for obesity treatment, not the other way around. Nutrition and lifestyle isn't supposed to be an adjunct to GLP-1s. GLP-1s are supposed to be added to that. And in fact, most physicians know all society guidelines for antihypertensive therapy, for cholesterol lowering therapy say the same thing. You should start with lifestyle. The foundation is lifestyle. Even if you want to start a drug at your first visit, it should be with lifestyle, nutritional lifestyle, not in place of or not replacing. This isn't happening in practice for all the reasons that we started to talk about. So I think GLP-1s are can be very effective drugs, but their side effects, their GI side effects, the muscle and bone loss, and especially the lack of adherence. About 60% or more of patients stop taking it at 1 year, and maybe 80% at 2 years stop taking it. And so they're going to regain the weight and maybe even be worse off because they've lost muscle and bone and regained only fat. And so we're hurting our patients if we're prescribing GLP-1s without giving them wraparound nutrition and lifestyle support. And I think that has to be fundamental. If we can give them that, then the GLP-1s can cause the acute weight loss, they can change their lifestyle. And then if they go off the drug, or even if they don't, they'll have a healthy diet, which will help maintain their long-term health.
So one of the things that came up, one of the comments I made when I was at HHS about the dietary guidelines was about the important role of dietitians. Right? And we think about healthcare at the AMA as team-based care, right? We all need to have the same philosophy, the same goals, but we have different roles in that. So what would you say about the importance of dietitians, Dr. Muzafarian or Dr. Gardner?
Absolutely. That we just haven't built a system that reimburses them adequately. Can't code for them and can't get them involved as much as they should. There's a big push now, as Daria has mentioned, to get more medical education for physicians, which would be great. But the dietitians spend their entire career on that topic. They are there. Like, so I know quite a few dietitians that I work that are a little insulted by some of the language that's going around. Like, we're here. We are here to support the team. We are part of team care. Include us. That would be great if physicians appreciated and utilize nutrition counseling more than they do, but we don't really expect them to be able to do everything that they're learning in medical school and take on nutrition. So I think some complementary role there. Include and engage more dietitians and get physicians more interested and engaged in nutrition themselves. Sure. Dari.
Yeah, I think giving doctors adequate nutrition training will only increase the value of RDNs, not the other way around. Just like giving them training about MRIs increases the use of MRI machines, or giving them training on physical activity increases the use of physical therapists, right? It's not going to hurt it. It's only going to be complementary. I think that there's been randomized trials of medical nutrition therapy showing that it has significant cardiometabolic and other health benefits. So we know that it works. I do think, though, that we have seen in our trials and has been reported in the literature, most patients won't see an RDN, even if you offer it to them, and won't see them more than once. And so we've had trials where we've offered free monthly RDN counseling, and only 20% of people will use it once, and only 14% will use it 2 or more times. I think that's pretty consistent. And so I think that we also have to develop, with modern technology, more asynchronous educational tools that are scalable, using AI, using videos, using toolkits, using culinary training. Christopher's works a lot in teaching kitchens and with chefs. And so I think patients have to be educated in different ways. And the RDNs will be really important for some patients. Other patients may want to go to shared medical appointments. They might want to go to a teaching kitchen. They may want to just say, leave me alone. Just send me videos I can watch by myself online. And I think that we need to bring nutrition education into kind of the AI present with some of these tools.
So this is a question that is personal to where I live. So I live in Flint, Michigan. About half an hour from here, we have our nearest Whole Foods. But on the north side of Flint, nothing like that. So what would you advise? I mean, what would you say to physicians who are taking care of patients like I just described, who have that restricted access to healthy foods?
So I'll suggest, and be interested to hear what Dari says here. I really think that over the last decade or so, people have recognized sort of and used 2 different terms: food swamps and food deserts. So food deserts are really no decent food to be purchased. And food swamps is there's this overwhelming amount of junk food to be purchased, right? And in some of those areas, some municipalities have created some zoning regulations that actually will allow a grocery store to come in and get some tax breaks in a place where they might have been reluctant to open up a full-scale grocery store. And some of the initial data suggests that the people in those neighborhoods go in and buy junk food. They don't buy healthy food, even though they have a grocery store, because just putting it there isn't enough to change those habits. So it really appears like not only do we need to put those stores within reach of people in need of the food, but we also need some supportive programs to show how this can be culturally adapted, how it can be affordable, when they can find time to do this. So just putting some whole food, even if it's not at the Whole Foods market, in front of them is helpful, but not enough. It's, again, as Dari was mentioning earlier, it's a systemic issue. It's a systems level problem that we have to address. I think physicians can play a role in this overall systems level change.
Yeah, I think Christopher summed that up really nicely, and I agree with everything he said, and we'll just add a few points. So data really matter here. And so we shouldn't just make assumptions about why somebody is or is not consuming nutritious food. And we've created a screener, a nutrition security screener, a 2-item screener that we've integrated into Epic. And so many Epic and other platforms now have social determinants of health screeners, but they don't have nutrition screeners. And so if anybody's interested, we're happy to share it. It's available online for free. And I would actually love to talk to the American Medical Association about advocating for this to be kind of integrated. The thing that's great about the nutrition security screener is in 2 questions, you understand if somebody has barriers to accessing nutritious foods, and then what the barriers are. And we've now implemented this in about 30,000 people around the country, and we have a paper published and several others coming out. But in one national survey, we found that, yes, cost was the top perceived barrier by far. And there were other barriers around physical access that you just mentioned, but there were many, many other barriers that had nothing to do with cost or physical access: disability, lack of cooking equipment, time to shop, time to cook, knowledge. Half of people who had barriers said, I don't know what is a healthy food. family traditions or family culture was reported as a barrier. So I think that implementing the nutrition security screener, which takes 2 minutes or 3 minutes, and asking your patient, what are your barriers, could be really helpful then to understanding what one needs to do to address it, whether it's physical access, transportation, knowledge, physical disability, cooking equipment, or other things.
Yeah, that reminds me, Dr. Muzafarian, of my lifestyle medicine board questions, right? I mean, when somebody comes in, it's not automatically, where are you getting your food? But you meet them where they are. Are they even thinking about that? And then start that conversation. And some will ultimately, like you guys just said, get to the point where, okay, I'm ready. But they don't have a place to sort of get to that next step. And so, yes, I think all steps are important.
And I will just note that online delivery is really starting to reduce this problem, online grocery delivery. So it's a little bit more expensive, but for the time saved and the transportation saved, I think we're getting to a place where this is less of a problem than it was.
So again, this is getting into specifics for a particular population, not with anything bad going on, but just age related, right? So are there adjustments for age-based dietary intake?
So certainly, older adults, if they should, particularly, probably one of the most important things for cardiometabolic health is prevention of muscle loss. And so I think combining adequate protein intake with strength training is really important. There's not a lot of evidence that just increasing protein intake without strength training will have as big of an effect. So it has to really be together. I think that's important. There are B12, other micronutrient deficiencies that can happen because of gastric and other changes that So I think there are some hidden micronutrient deficiencies, which are quite common. And then for many older adults, it just becomes an issue of sort of frailty and time and cost, and they're really subsisting on staple foods and quite malnourished, actually. And so I think for patients who are quite sick, we now have programs in many states and growing of medically tailored meals. You can actually get them about half of their meals delivered to their home if they have chronic conditions. So I think we should really be expanding medically tailored meals. And I know we just have a couple minutes left, but I want to hopefully just in the last couple minutes highlight some of the future policy directions, I think, that the DGA's emphasize. But I'll turn it over to Christopher if you wanted to add anything about aging.
The only thing there was, a lot of times there's depression and loneliness getting in the way of some of what's going on. It's a tough time of life for many people. And again, more protein, more vegetables on the plate won't really help if we're not addressing their dentition issues and other complicating factors that Dari was bringing up. Go for it. I'm done. I want to hear these political issues or policy issues for the future.
Yeah. Well, I just wanted to point out a couple things, and Christopher mentioned this a little bit. The dietary guidelines is just a piece of paper or online website if it's not translated. And so what do we want to happen? What are we going to look for? First, they need to be translated to the public, as was mentioned. And historically, there's been very little budget and very little attempt to do it. There's some things that are created, but the public doesn't actually receive those. And so far, we're seeing very encouraging signals in terms of ads and public speaking, other things that this administration is going to focus on dissemination to the public. So we need to make sure that that happens. Otherwise, if the public doesn't know that we're updated, it won't be helpful. And then secondly, there's many programs that Christopher mentioned, like school meals and others, military nutrition, federal procurement guidelines for cafeterias and office buildings that are supposed to follow the guidelines, but the agencies actually have to actively update the rules, which can sometimes take 5, 10, 15, 20 years to happen, not months, years, or never happen. This administration has again indicated publicly that they're going to rapidly move to implement these into some of these programs, school meals being probably the biggest one. So I think that's really, really important to watch and to see if they do. If they do it this year, that would be lightning speed and would be kind of incredible. And then thirdly, states are really there's at least 30 states which have bills or other activities around processed foods and ultra processed foods. So states might actually implement the dietary guidelines in some of their policies. So those are all kind of big issues we have to kind of follow and watch. And it seems like compared to previous years where, the dietary guidelines come out and nothing really happens, and 5 years later they come out again and nothing really happened. Like things might happen fast this time, and you have to wait and see.
Well, thank you, gentlemen, for this amazing time to provide insights to the history of the U.S. dietary guidelines and helping us unpack the newly released dietary guidelines. So we appreciate the important work that you do and are grateful to both of you who are able to share your expertise on this topic. This is the first event in a series of webinars that we're going to be organizing on healthy diet and dietary patterns. Please mark your calendars for the next webinar, which is going to be on Wednesday, April 29th at 11 Central, noon Eastern, lunchtime. So that session will focus on understanding the science of processed foods. A link to the registration for those events in the series will be sent to today's attendees. CME is available for today's webinar, so just make sure you're signed in to your free AMA EdHub account and click on Take the Quiz. Thank you for joining us today. We very much look forward to seeing you at our future AMA educational webinars. And we're going to keep it focused and get us healthier. Thank you.